to welcome you all to the Oncology Cancer Treatment Update 2025 webinar. Today, we gather to explore the latest advancements, research, and innovation in cancer care, all aimed in improving patient outcome and shaping the future for oncology. A big thank you to our esteemed speaker and each of your commitment to learn and collaboration. Let's make this session impactful and insightful. Once again, welcome you all. From now onwards, I would like to invite Dr. Nayanti R. She is a consultant medical oncologist at Saroj Gupta Cancer Center and Research Institute, Kolkata. Over to you, Dr. Nayanti R. I hope I have pronounced your name correctly, ma'am. Nayanti, ma'am, am I audible? Nayanti, ma'am? Just a moment, ma'am. I'm just checking with Dr. Nayanti. Please, voice is not coming.
Okay, okay.
Nayanti, ma'am, am I audible?
Am I audible?
Yeah, ma'am, you are. Yeah. So, Nayanti, ma'am, the stage is all yours. Ma'am, should I share your slides or you're sharing with from your side?
No, I'm going to share the slides from my side.
Just a moment. Ma'am, you can share the slides right now.
Okay. Are the slides seen?
Ma'am, you have to just open the slides. It's not able to.
1 second. Yeah, is it seen now?
Yeah, it is. It is. Okay.
Okay. So can I start?
Yes, ma'am, you can start.
Okay. Good evening, all. I thank AstraZeneca and Dr. Varun Goel for giving me this opportunity. Today, we'll be discussing and dwelling regarding what is the need for the molecular biomarker testing in lung cancer, how can we do it, and what is the importance of it. So my entire presentation, the overview of the presentation would be that we'll be initially discussing the incidence of lung cancer in India and what are the various biomarker testing which happens in the non-small cell lung cancer. How did the evolution happen, like from the past and the current, and then the final takeaways of this. So why is the lung cancer and their biomolecular testing so important? These days, it's not optional. It's become imperative. Why? One, looking into the burden of the lung cancer based on the Globocon 2020. If you look into the data, both in the incidence in both the sexes and in the incidence death rate is quite high. So based on these factors, lung cancer, initially we only used to give chemotherapy because of the various optional targets available and the various mutations which are dealt with. The overall survival of all this has been increasing now. So with this, if you look into the data of various driver mutations which are being present, almost 50% patients of non-small cell, both the adeno and the squamous, have a dire mutations. The various drivers which are involved are like the most common being the KRAS, almost 25%, and with the KRAS G12C, where which we have a target, that's 13%. And the other ones are EGFR, ALK, MET. I won't be going in detail of this. Mostly, I would be dwelling into how the molecular testing has evolved, what is the need of it, the various treatment per se, and the treatment related will be discussed with my colleagues. So first coming to the importance of this biomarker testing. Why is it so imperative these days? Why can't we just do it like optional and give a treatment in general to all patients? If you look into the Kaplan-Meier graph here, this says that most of the patients who have a targetable mutation, the median OS has increased compared to the ones which don't have, which is almost like 18 months increase in the median OS. So with this, there is various guidelines like ASCO, NCCN, ESMO, even the CAP guidelines recommend let it be a 5 gene panel, an 8 gene or a 12 gene or an 18 gene assay based on the affordability of the patient. These genetic testing has become important these days. So what are the various methods? I'll be dwelling more in detail, but this is a brief introductory part that can be divided into an DNA sequencing, an RNA, and other is a FISH. So brief about the DNA, it can be detects the insertion and the point mutations based on the NGS, like EGFR, KRAS and all. RNA sequencing tool mainly detects the fusion abnormalities. The best example will be the ALK fusion. And the other FISH can be the PDL1 testing or even an ALK and ROS testing. So evolution of these biomarkers. So how did this evolve and what was the past and what are the current? So if you look into the journey of analysis part, initially we diagnose a patient both on the clinical and the radiological aspects, then the biopsy or the specimen method. So we do it on a tissue based, then basically fix them and then go for a histological analysis, DNA extraction, and a cytology either from the pleural fluid or whatever the specimen of liquid we do get, and finally comes to liquid biopsy. See, all these techniques I'll be discussing in detail and in depth about it. One brief note regarding the current and the future is the proteomics, where even a single gene panel and the protein study and even the metabolics of it, something like a metabolic pathways of it can also be diagnosed with all this extraction process. So as the old school method, what is the biopsy? Why is biopsy so important? Definitely, once is the confirmation of the disease and histology, and also the grading of tumor. Maybe any other testing wouldn't be doing so. So it grades and the histological confirmation, and based on this, various other pathways can also be diagnosed based on the biopsy tissue specimen itself. But the most drawback of this is a tissue fixation and the time and the turnaround time and what time the analysis takes part. This is the important thing which we need to keep in mind also. So for an entire TAT time is around 10 to 14 working days, which is required in this process. So next coming to the importance of what is this circulating tumor DNA. Most of all, whenever we are doing a liquid biopsy, it's very important that tumor does shed some DNA or RNA. So it enables the detection. So it enables in a diagnosis process, then the monitoring of the response. And again, it also overcomes various associated challenges. One important thing, especially in lung cancer, we do see that if a molecular target is available, if we diagnose it and start a specific targeted therapy for a patient, the patient does progress. The resistance part, instead of going for an invasive procedure, just a blood of 5 to 10 ml enables us to know the resistance pathway. Most of all, it's the tumor heterogeneity. For example, if we do a tissue biopsy and if we get a necrotic tissue, maybe we won't get a conclusive study. But this is not the case with the ctDNA. But still, one important gold standard is biopsy. Biopsy is mandatory in all patients if it's possible. Only the patients who are not a fit candidate, and also in case of a prognostic or predictive or response assessment, a ctDNA holds good. So coming to the procedure and what is the importance in case of a neoadjuvant or in case of a surgery. So here I would be discussing regarding the study called the tracer study. So this is basically extracting the tumor DNA in this patients who are basically in an operable or an resectable setting. Upfront itself, the patients, almost like 24 subjects of patients were included in this. And in this study, when the patients were subjected to neoadjuvant therapy followed by surgery, post the surgery treatment, they analyzed what was the MRD of the status. Most of the patients who had an MRD positive, that is the positive circulating tumor DNA, turned out to have a distant recurrence in a very short span than with the compared to the patients who didn't have an MRD. So this can also become like a predictive along with the prognostic marker. So the traces study basically it explains us how the evolution with respect to treatment and the outcome in case of a profiling and also for the confirmation of the MRD negative status. It enables us to plan this treatment of a patient in future. And in other solid tumors also, like in colon also, this is still an upcoming one. So based on this, a positivity or a negativity does hold an implication in the future management. So a brief note on the comparison between the tumor tissue and the liquid biopsy. Definitely, if you do a biopsy, it's an invasive procedure, and other parameters like the bleeding time, the clotting PTNR has to be kept in mind. Whereas for a liquid biopsy, just a normal syringe procedure, 10 ml blood is drawn. Sometimes, because of a necrotic tissue, a repeated biopsy may be required. In case of a liquid biopsy, if the tumor shedding doesn't happen accurately, then definitely it may lead to a false negativity also. The main important part of the biopsy specimen is it says the confirmation, the histological per se, the cellular phenotype, which may not be so in depth with the liquid biopsy. And the sensitivity assay is almost lower because of the tumor cell content, and it's very high in case of a liquid biopsy. The analytical standardization, again, it depends upon, it's again a pathological observer variant. So some pathologists may do say the grading part or the LVI, PNI part can be differ. So this part is not taken into a liquid biopsy because of the standard existing performance status. And also in clinical utility, so you can't subject a patient with a PS4 to do for any invasive procedures. In those cases, definitely liquid biopsy still holds good. So this is just a paradigm which shows that how the testing has been done and how the testing of NGS has evolved. Initially started with a single gene, like just a basic single gene testing was done. Now we have a multi-panel assay. So, and based on that, the respective targets are being given to the patients also. So coming to the advantages, so why do we need to subject most of the patients to NGS testing? One, definitely within a short span, the TAT is less, an entire genomic panel. It's not only a single gene, even a multiple gene. So we can know what is the driver mutation, what is a hitchhiker mutation which has been present. It helps us to understand the tumor biology as a whole. It's more like a holistic approach being given. Definitely, the cost is one important factor to be kept in consideration whenever the treatment is being planned. So I'm not going in depth regarding the techniques, but just let us know. This can analyze both the single nucleotide and also a copy variant together simultaneously instead of doing as a single procedure. So if you look into the pathways of various non-molecular and non-small cell lung cancer, we have the EGFR1, the KRAS. So umpteen number of mutations along with the resistance can be given in depth in the NGS sequencing. So like even a KRAS G12C mutation, almost the frequency of 20 to 30% diagnosis can happen with a PCR and DNA sequencing. I'll be explaining in depth regarding each of the things. So first coming to the EGFR mutation, which is seen in lung cancer. So again, we know this can be two testing. One is with the tissue biopsy specimen or with the liquid biopsy. So the samples, even a cell block, like you take a pleural fluid, if an adequate cells are present, even with that, a cell block can be made and the diagnosis of this is possible. So where do you take the biopsy site? Has this to be a metastatic lesion or the primary? Again, it depends upon the accessibility, the SUV uptake, and as a whole, how the patient's performance status is present. So there might be a discordance between the EGFR mutation in the primary and also in the corresponding metastatic site, which need to be kept in mind. So when you look into the guideline per se also, now we do have even an early setting. Initially, the EGFR testing was only considered for a metastatic setting, but currently even in a stage 1B onwards, EGFR testing is recommended because we have adjuvant treatment for that. I won't be dwelling into the treatment aspect per se, but just in the molecular part. So the indication starts from stage 1B onwards, even in case of an operable tumor, because of the availability of the adjuvant treatment options. So what are the advantages? So main thing is if you look into the PCR, if you look at the PCR or the NGS or even if an IHC testing, what is the advantages of an NGS here? So main important thing is almost like 48.6% of mutations were identified which by NGS, which was actually missed by a PCR in that. So whatever the mutations, the variants, even the resistance pathway, which was not being given, this was very well in depth explained by an NGS report. As a whole, there is a benefit of doing an NGS testing, especially with a targeted PCR-based approach, or even if you read the genomic part as a whole, exome genomic sequencing part, the strategies are better. As a result of which, we do have the 12 gene NGS panel and even the 18 gene, which corresponds quite good in these cases. But if the patient is not affordable, definitely a PCR is still holds good in this because of the cost constraint. So now coming to the ALK. Does all patients of ALK rearrangement do need NGS testing? Not necessarily. See, ALK sensitivity is quite high in case of IHC itself, almost 93 to 100%. So this not definitely required a confirmation with FISH. The false positivity rate is almost 0.1% with FISH. So as a whole, if the patient is not that affordable, IHC still holds good. But in case if you're just testing the entire genomic panel, a part of it, NGS testing is also quite high. For ROS rearrangement, what is the mode which is used? Again, you can get ROS by FISH or any other molecular testing. See, one important thing is whenever we are doing an individual gene panel, let it be EGFR, ALK, maybe we can use a molecular testing, but as a comparatively as a whole, definitely NGS still plays good. That's like a confirmatory testing, which we can see. So whenever, if you look into the sequencing paradigm of this, first the patients are subjected for EGFR and KRAS testing. Again, the ROS. Again, ROS by IHC is being done. If ROS is positive on IHC, reconfirmation by a second method, that a FISH or a molecular assay can also be used. But if it's ROS, positivity can also be reconfirmed with IHC also. As a whole, but if you do a single NGS testing, this reconfirmation is not required. So coming to the KRAS mutation, why KRAS is so commonly used, and as we know that especially most of the people are smokers, which is quite high, especially with G12C target available, this is almost found in 13% of patients. So this can again be assayed done with a single gene testing or a multi-gene NGS panel. Most importantly is the acquired resistant mechanism can also be observed with knowing the down-regulatory pathway. The RAF-MEK-ERK pathways can also be diagnosed with a proper NGS panel assay testing. So another note on the BRAF mutation, if you look into detail of it, as we all know that any downstream pathway of EGFR can also be targetable because again, if there is a dual mutation, the predictive as well as the prognostic implication of the treatment does vary. So for BRAF testing, more than 50% mutations have been identified. As we all aware of the tumor agnostic therapies now with multiple progressions, almost 1 to 5% patients of the overall mutations still do benefit with this testing. And all these panel NGS is generally used because as a whole, one go, we try testing everything. Again, for a BRAF testing, if you look into the downstream pathway, the MEK pathway, the resistance pathway can also be given in a single testing. And coming to the c-MET, which is one of the most important, the most common being the MET exon 14 skipping mutation. So if there is a normal splicing and there is an abnormal splicing which is being diagnosed, this can also be diagnosed with DNA or an RNA. See, this is the division pathway. First, there is a splicing 3' splicing which occurs, then goes an mRNA pathway. So this can either be done with a DNA sequencing or an mRNA sequencing. Again, it depends on which type of testing we are using here. So the method which are commonly used for the exon detection are PCR. Again, because of the technical consideration, the most important IHC and FISH has not been recommended because of the false positivity and the low detection rate. So the best for the detection of a skipping mutation would be NGS. Yes, again, it depends on which type of mutation we are looking for. A DNA definitely detection for many mutations, but an exon skipping one, RNA holds the utmost sensitivity. So coming next to the other one, the other target is the RET receptor tyrosine kinase, which we look into why are all these mutations important? One is, do we have the targets? And if there is any dual mutation, so if there's a coexisting, which one to target first, again, happens more importantly. As we all know that 1 to 2% seen in lung cancer, most common RET mutations are present in papillary thyroid carcinoma tumors, almost accounting to 10 to 20%. Again, this being a very uncommon mutation, the testing is best done with using the NGS DNA sequencing. Sometimes even an RNA sequencing can be done because as we know, the downregulatory and the break which has been seen, based on the mutation which has been present, either of the sequencing can be given utmost importance. So what are the pros and the cons if you're using an IHC, FISH, or a DNA and RNA sequencing, especially in case of a RED? As it's mentioned that IHC and FISH, because of high false negativity, is not recommended, but only in certain cases wherein, okay, the patient's affordability, especially in case of CA thyroid, still recommendation of FISH is indicated, but not in case of lung. And then if we look into the DNA and the RNA, even though it still holds good, there is some coverage. There is an issue with the poor coverage. So whenever we do an NGS pathway, we need to look into a good coverage, the number of cells being present. So with the DNA sequencing, there is intronic areas because of which there might be a false negativity. So definitely RNA holds good because of the high dependent and the quality of it. So this leads to the reduced sensitivity. So majority of red fusion can be detected with a DNA sequencing NGS, but sensitivity with RNA is increased these days. So coming to other targets like NTRK, which is very important not only in case of lung sarcomas because of the tumor agnostic therapy, the various options again are the IHC, RNA, DNA, and the various FISH and RT-PCR techniques. But most commonly these days, especially in case of a lung cancer, because of the reflex testing, which we have seen along with the 12 and the 18 gene panel, NGS is used. Again, the sequencing, it depends upon a whole exome sequencing or what type of sequencing we are trying to use. So if we look into the comparison path, yes, the advantages can also be in IHC, FISH, and an NGS. But most important, RNA sequencing is coming up because of increased sensitivity and specificity. The most important pathway of the main drawback of the NGS is the TAT time, which is quite important, and the cost which has to be taken into consideration. So IHC still holds a reasonable option for an NTRK testing, but because of the low prevalence, an NGS testing is still recommended and mandatory. So finally coming to another target called the HER2 mutation. Why these days it's important? Because of NR2, which is commonly used in all these patients post multiple lines of progression. So the percentage seen in the incidence is almost 3 to 5%. Mostly it is an exon frame. So again, if we look into the mutation which has been present, it can be a HER2 mutation or an amplification. So this is something similar like breast, not like something gastric. So this has to be taken into consideration. So IHC, yes, still holds good for this, and HER2 overexpression is almost seen in 59% of the cases. So again, the 3+ confirmation is seen in 30% cases of these patients. So coming to the molecular paradigm, if we look into the advances, so initially the way we evolved in the treatment from the chemotherapy to the targeted, coming to the immunotherapy per se. So EGFR mutation, again, post-progression, definitely we do look into an IHC based or an NGS or a PCR based, ALK, FISH or an IHC. Again, ROS, the confirmation is by an NGS. So if you look BRAF, NTRK, RET, MET, as a whole exome sequencing, this comes as a single gene panel and we can do with a single go technique. So now coming to the most spoken one, that's the immunotherapy and the PDL1 overexpression, which has been present. So what are the various platforms which are used? So the various platform, again, it depends upon what type of immunotherapy we are using, whether it's a PD1 or a PDL1 inhibitor. The most common PD1 being the pembrolizumab, for which we use the DACO platform. Here, again, it depends upon the tumor cells which are being present. It's more than 1%. If it's high, if the tumor proportion score of more than 50%, the scoring system keeps varying. If it's a Ventano, again, most commonly for the durvalumab, again, SP142 Ventana platform and atezolizumab. So this looks into the tumor cells, the staining per se pattern, and what is the proportion of staining present into it. So if you look into the various different testing, this is this is a slide which depicts that how the positivity varies in a Ventana platform and the DACO platform. If you look into the SP263, the staining is quite intense, and if you look into the SP142, the staining does vary into these. So these are the one of the most important thing for an immunotherapy based approaches. So, for example, we have various immunotherapy biomarkers and we do the PDL1 testing. So, are the PDL1 testing a sole marker for immunotherapy? For example, if it patients turns out to be PDL1 negative or the TC score, or if it's less, it's somewhere 0%. So what are we going to do? So are we not subjecting the patient for immunotherapy? Now we have a different synergistic approaches. The most a little bit mostly added with the chemotherapy. So how to do that? One is called the tumor mutation burden, because looking into the neoantigen per se, if there is a high TMB of anything more than 10 megabase pairs, and looking into the tumor agnostic therapy, some of the checkmate studies have implicated even in PDL negatives per se, but with high TMB, we can still use immunotherapy. The other predictive biomarkers or other various biomarkers which have been still controversial but still evolving. One is the MMR genes. So we look into the various MMR, the 4 genes are taken, but it's not relevant in lung. Maybe this is very important in case of colon cancer, but still this is still evolving. So we can keep this into consideration. And other most important one is LAC3. Again, this is not being currently used in lung cancer, but maybe in melanoma, something there is a target called relatimab with the combination of nivolumab. So right now in lung, maybe PDL1 still holds good. Maybe as we develop further in future, maybe other predictive biomarkers like a TMB or an MSR high, which holds good in colon, or even a LAC3 can still take into account in future. But currently, the ultimate thing for today would be the PDL1 still holds good. Based on that, we do take into a treatment consideration. So I would like to conclude that with the study, as we all know that these days we are living in an era of tumor agnostic and precision medicine. So all patients need to be given a good oncological treatment. So in those cases, it's not an optional treatment, but as it mentioned, it's an entire biomarker repertoire, which is very important to drive these testings. So biomarker testing has evolved. Initially, it was a single gene. Now it's a multiple testing. Again, it depends upon the various platforms which you used. What are the sequencing method? It can be an RNA based or a DNA based or an whole exome sequencing also. So it's more like a multidisciplinary one to understand not only just a histology of the disease, but we're knowing the entire concept. We know the tumor biology, what is a specific driver mutation, and what are the added on hitchhikers or a passenger mutation? If there are any coexisting mutations present, like for example, there's an EGFR and a P53, maybe those prognostication is quite bad. So if we can explain the patient better, like this is your entire holistic approach, just not of the biology, but even the molecular based approach can be given. Other most important thing is initially, as we know, the TAT time for a biopsy used to take 10 to 14 days, but now with a span of 10 working days, we can get a result in NGS based testing. So the sample, most importantly, should contain adequate tumor content. Like even if the tumor shedding has been done, and if we have a good circulating tumor DNA cells, definitely these holds good. So these patients need not be gone for an invasive biopsy procedures. So one important is the TAT time, other is the molecular driven approaches, adequate tumor tissue, and most importantly is the high thorough output. Like Albert, we look into various NGS platforms, the several genes which are taken into account. So we are able to understand the holistic approach of it. Based on that, looking into several genes, the molecular per se in one single panel with a specific time duration, and as a result of which we know both the predictive and the prognostication of the patient, and also the various targets for it, and looking into various resistance pathway also helps into it dealing in depth about it. So with this, I would like to conclude saying that definitely we are into a molecular era. NGS testing is one of the most important thing, I think, for almost holds good for all tumors. Evolution started with melanoma, then came up lung, where the survival has increased with all this. So thus, it's very important that whenever we are subjecting a testing for the patients, we need to consider the economical per se, the outcome per se, and also the implications of the treatment of it. So with this, I would conclude my talk. And again, I want to thank AstraZeneca and Dr. Varun Goel for this. Thank you.
Thank you so much, ma'am, for the excellent talk. Uh, Next, moving forward, I would like to invite Dr. Tanushree Mishra. She is consultant radio oncologist at ESI Hospital, Bhubaneswar. Over to you, ma'am.
Good evening, everyone. And that's it. I would like to thank the organizers for giving me this opportunity. Let me share my screen first. Hmm. Hmm. Is my screen visible?
Yeah, ma'am, it is visible. Can you make it full screen?
Yeah, yeah,
Yeah, it is.
yeah.
Yeah, it is okay now. You can
Okay,
proceed.
okay,
Thank you.
thank you. Thank you. So, good evening, all. So, today my topic of discussion is overview of lung cancer. After the excellent talk of my previous speaker, ma'am has explained everything what is needed today about lung cancer. So, I will be touching the basics. So, going further, the burden of lung cancer, according to Globacon 2020 data, lung cancer in India, if we consider both the sexes, then it is the fourth most common cancer in lung as per incidence. But if we consider only male, then it is the second most common cancer. So, constituting about 8% new cases every year we are getting in lung. According to 2020, now I think it must have reached about 13% or 14% because the incidence of cancer as such is increasing in such a high pace that every cancer's incidence we are getting, no doubt we are getting less number of cervical cancer now, but breast, lungs, head and neck, we are getting more and more in number. So this is the data in both the sexes. If we see, it is the fourth most common, and if we consider male only, it is the second most common in India. Now, after coming to after diagnosing, after seeing a case, we must do a staging. So in lung cancer, it is very important to do a optimal staging because everything here depends on the stage. Because our plan of treatment, what we should offer to the patient, that depends on the stage with which he or she comes to us. So in AGCC 7th and 8th, there is a little bit difference about the size of the tumor, then the staging upgradation. But this stage, from stage 2A to 3A, in between 2B also. So this is the gray zone where means we are always in dilemma that what should we do first? Should we offer neoadjuvant therapy, or upfront we should go for surgery or chemoradiation, or what should we do? So it depends on many factors, and patient's general condition, then nodal burden, and everything that depends on that. But this uh, zone of stage people, that tumor size about 5 to 7 centimeter, and N1 disease where there is high incidence of, there could be occult N2, will be coming to that later. So this stage people, they are very much crucial for clinicians also. They always discuss in tumor boards vigorously with all disciplinary cardiothoracic surgeons, then radiologist, then radiation oncologist, medical oncologist, surgical oncologist. They all sit together to decide what to do with these patients. So, what are the investigations we should do to do a proper staging? As we all know, but in basically in lung cancer, first in the peripheral setting, when the patient goes to physician, they must have done a chest X-ray. Then, if suspicious, they would have done CT scan. Then they would have sent to you. But when the patient comes to you, if they don't have a CT scan report, we must do a bronchoscopy, CT scan, then PET CT, and then this endobronchial ultrasound, esophageal ultrasound, and mediastinoscopy. I don't think everyone is doing. There are certain centers where experts are there to do this, and when we really do need and mediastinoscopy, we must send the patient. That we'll be discussing later. And next, MRI brain. We all are having facilities of MRI brain. So these are the basic cascade of investigations we must do, and we are doing in our clinical practice. Next, coming to CT scan versus PET CT for staging. This stage three, what we are discussing this, because this lymph node that that plays an important role regarding the management of the patient. So as we all know, in any clinical practice, if the node is more than or equal to 10 mm in their short axis, then it is a predictor of any malignant deposit. So on CT scan alone, it has a limited role because of low sensitivity around 50%, 55%, and low specificity around 80%. So it may help to selecting appropriate procedure for tissue sampling by providing the images. It may give you the clue that you must do a guided biopsy or FNAB from there, but it is very important to know whether this could be a secondary deposit or not. That cannot be confirmed many times on CT scan. So additional this PET to CT will provide the metabolical activity of the node, and it will provide overall sensitivity. It will increase up to 90% and specificity also up to 95%. So PET should be done in all stage 3 cases. Then this occult N2. Why this is not always detected by general screening? Because this occult N2, these are the para-aortic nodes, autocaval nodes. These are some kind of hidden nodes. So which set of patients we must put them for mediastinoscope to see these nodes, or we stamp them with N2? These many studies have been done, and it has been seen that the centrally located tumors, when the tumor is centrally located, size of tumor more than 3 centimeter or 6 centimeters, 6 centimeters, mostly 6 centimeters, 5 to 6 centimeters tumors, they have a greater incidence of having occult N2 nodes. And when on PET CT we see that more than 4 SUV we are getting, then we must subject these patients that mediastinoscope, because they are very much they are having risk of occult N2. So mediastinal staging, this is less invasive procedures, sir, esophageal ultrasound, endobronchial ultrasound, and biopsy, but invasive is mediastinoscopy. We physicians also, we sometimes get feared by the name of mediastinoscopy. So what about patients? So we must select the patients very judiciously, that those patients we are subjecting them for mediastinoscopy, actually it is only the method they need. After going through literature, we can see that the centrally located tumors are more than 6 centimeter tumors. When SUV more than 4, then if we are not getting a clinically N2 node, then we must subject them for mediastinoscopy. Then VATS is mostly, it is very sensitive and specific for detecting nodes. We'll be coming to that later. Then mediastinal staging, as we can see here, all stations. These purple ones are stations 1. Then this supraclavicular zones, nodal stations. Then superior mediastinal nodes in the upper zone, if N2 is there, ipsilateral or bilateral, that mediastinoscopy is needed to detect these nodes. Then outer pulmonary zone also, this zone is sometimes not visible in CT scan. And inferior mediastinal nodes in the lower zone and in the hilar zone, these can be seen either in the esophageal ultrasound or in CT scan. These interlobal nodes or peripheral nodes are possible to see. So recommended techniques are endobronchial ultrasound or esophageal ultrasound if clinical suspicion of N2 involvement remains very high, even after a negative endobronchial ultrasound or esophageal ultrasound. Then surgical staging with mediastinoscopy is recommended. We must know that there is node or not. So when is invasive mediastinoscopy is indicated? When centrally located tumor is more than 6 centimeter in the study, but they have seen that even if centrally located more than 3 centimeter, there are more chance of N2, occult N2. Extensive infiltration of mediastinum with no evidence of extrathoracic disease, and N1 positive. This is important. N1 positive with extensive infiltration of mediastinum. Then we must subject these patients to mediastinoscopy. Then bulky N2 on CT, no need for invasive procedure, because as such on CT we are getting a bulky N2. And if discrete N2, yes, we should do regardless of PET CT result. And normal mediastinum on CT, but positive on PET. Positive of PET, then we must see where the node is. And if negative on PET, then we should not. This is the overall protocol we should follow in every patient. After PET-CT with intrathoracic lung cancer with or without enlarged lymph nodes, we are getting a patient, and these patients are mediastinal lymph node negative. If clinically negative and unforeseen N2 disease after negative PET-CT probability is very less, we see, then we need not go for any further investigations. We must put the patient for radical treatment. Then if mediastinal lymph node is negative, but clinically N1 or CN0 and high probability of N2 is there, even though PET negative, we must subject them for endobronchial or esophageal ultrasound. If then also mediastinal lymph node negative, then we can go for treatment. And if positive, then our treatment modality will definitely change. And if mediastinal lymph node is positive with PET, then what should we do? If bulky lymph nodes, no tissue confirmation is required, we can directly go for protocol-based treatment. And if non-mass or non-bulky lymph nodes are there, tissue confirmation is required through either endobronchial or esophageal ultrasound. Mediastinal lymph node, if negative on tissue, then multidisciplinary evaluation for surgical staging should be done. And if lymph node negative, then radical treatment. If positive, then again we can think for neoadjuvant. Then mediastinal lymph node positive, this multimodality treatment should be considered. So this is in nutshell decision making. Now coming to lymph node stations accessibility, as we have seen in the previous picture, that according to the station, their location means supraclavicular, then superior mediastinal, inferior mediastinal, and peripheral, their method of investigations would be different. So this slide depicts that only, and we can see the in every station this TEMLA and VATS, they are having a high degree of sensitivity, but gradually we can see for every station we are having different modalities of investigations that clinically we can assess and we can advise a patient to do that. We will not we will never advise a patient to go for transesophageal ultrasound for a obvious supraclav node when other everythings are negative. So that is a clinical decision. And non-invasive and invasive staging modalities are several, are many modalities are there. We have to choose non-invasive and most sensitive. Always we must do for a sensitive one, because we may lose a positive case, we cannot afford that. So according to sensitivity, VATS 99% sensitive and CT scan is only 55%. So for different nodal stations, their uh, performance also varies. So for upper mediastinal, all modalities are well and good, we can go for. But for lower mediastinal, endobronchial is not needed. For autopulmonary zone also, this endobronchial is of no use. For hilar station, it is important. But for mediastinal, again, mediastinoscopy is may be needed for hilar stations, but it can be detected through CT or PET. So we always should choose for a non-invasive method whenever possible. Now coming to evolution of therapy in lung cancer. So previously, when we were seeing any case in our student career, when a lung cancer patient were coming, we were only treating the patients basing on the histology report. Small cell, non-small cell, if non-small cell, then squamous and non-squamous. That was our concept. Okay. So at that time also TKIs were there, adenos, EGFR were doing. I'm telling before that in long back, that was the concept that only histology was there. After with evolution, then we got molecular markers that EGFR, Alcross, these things. So they become the standard of care in every patient. We must advise. If we will not advise, we are committing a mistake, we are committing a crime. We cannot omit the molecular marker in a non-small cell lung cancer, that too adeno. Then after that, now the era is of tumor mutational burden and PD-L1 expression for immunotherapy. So this is the era of immunotherapy. Almost all immunotherapy agents, they are having their trials, their successful trials in advanced cases, metastatic cases, and also now they have come up in early stage also. In first line recommendation, we can also have these immunotherapy agents. So we'll be come to that later. So we can see that advances in management of non-small cell lung cancer has improved with modalities of therapies that has evolved. So lung cancer specific survival has improved from 26% among men in non-small cell lung cancer, that was those who were diagnosed in 2001, as compared to 35% those who were diagnosed in 2014. So in 14 years gap, many molecular markers have been developed. So and accordingly treatment has also evolved. So we are that once uniform will not fit to all. It's not the police uniform also that varies from size to size. So accordingly, like this tailored treatment has concept has came, and not one treatment will fit to all. So accordingly, when they are diagnosed with different molecular markers, their treatment has also varied, and they lived longer than previously diagnosed cases. And advances in treatment of early and late stage non-small cell lung cancer with targeted and immunotherapy, we all have experienced in our clinics. So it is no need to explain this, but we can see that this yellow one is only histology. Then blue one is targeted, and this orange one is immunotherapy, and immuno plus PDL1 selected by histology is this red one. So we can see that today, at the time of 2020-25, we are using doublets of immunotherapy. Not only singlet, we are using doublets. And they all have been approved by USFDA, NCCN, ESMO, and ASCO. All they have approved this guideline. So previously in 2006, when they were treated only basing on the only histology, then bevacizumab was a game changer. When bevacizumab was added, patients lived longer. Then came the platinum and pemtexid in 2000, around 910. Then after 2016, these immunotherapy agents came. In between that 10 to 16, these 5-6 TKIs, they played extensive immense role in patients of lung cancer, when where this first line gefitinib, then further further molecular testing, with further molecular testing, that is ALK, ROS, and all those subcategories when being diagnosed, then crizotinib, erlotinib, lorlatinib, they all came to a clinical practice, and they have changed patient scenario. We have patients with stage 4 lung cancer with brain mets on lorlatinib for more than 5 years. You must be having patients on crizotinib for more than 6 years. Everyone is having their own experience with these magic bullets. They are really magic bullets. Previously, chemotherapy agents were not so effective. Patients were not tolerating the side effects. So with only a diagnosis of a molecular marker, we can add few years to a patient's life. And with the invent of this immunotherapy agent, we can add a quality life to the patient. So this is the difference. Now coming to the molecular targets. So as we are discussing the previous slide, 7 molecular markers, they are approved by USFDA. They are mandatory nowadays. We cannot omit them. EGFR, ALK, ROS1, BRAF, and NTRK, MET, exon 14, and RET. We cannot omit the testing of these things, because we have specific agents for that, and they can definitely increase patients' lifespan with use of that. So this increases the need of molecular testing in non-small cell lung cancer, and it should be the standard of care, and it is the standard of care. No one can deny that. We can go for NGS, as ma'am has said, we must do, because we never know, newer molecule will come and that will help. So we are having, if we are having tissue, liquid biopsy is okay, NGS is good, but always tissue biopsy is better than liquid biopsy. So we must advise, because now with help of, thanks to AstraZeneca, Ross, and all these companies, they are providing us coupons for free for the patients. They can do these testings free of cost. Now, current guidelines for neoadjuvant adjuvant chemotherapy depending on the disease stage and finding during surgery. So, in a pathological stage 1, where no lymph node is there, we can no proven benefit for neoadjuvant or adjuvant chemotherapy. We can wait and watch what happens to the patient with close observation. 3 monthly, we can follow up the patient, and we can wait and watch. Then in stage 1B, 2A, where there is no lymph node but multidisciplinary team should discuss about observation versus adjuvant chemotherapy in high risk patients where no proven benefit of neoadjuvant therapy is there. Till stage 2A, there is no proven benefit of neoadjuvant. Then comes to stage 2B, when N1 node could be there, where adjuvant chemotherapy is definitely recommended, but no proven benefit of neoadjuvant chemotherapy. So when surgical staging is done upfront, operable cases, we must stick to this protocol. Then stage 3A onwards, when N1, N2 nodes, here we can think of neoadjuvant chemotherapy or adjuvant chemotherapy or sequential chemotherapy with radiation therapy. When bulky node is there, we must go for radiation therapy. We should not omit that. We will come to that later. Then coming to after surgery, we are getting a negative margin, no residual tumor, complete resection is there, R0 resection, well and good. We can follow the previous protocol. If margin is positive or residual is there, we must, according to means protocol, I am telling that we must subject this patient for resurgery. But you can say in which uh, uh, where those surgeons will they go for resurgery? Would you subject these patients again for use surgical burden for resurgery? No, no one goes for resurgery for a positive margin. Yes, it is possible when frozen section is being is available, and frozen section should be available in all where all these complicated thoracic surgeries are done. So after everything, if on pathology report, if we get a R1, then we must go for radiation and chemotherapy. Surgery is theoretical here. Very few centers, they must be subjecting the patient for resurgery. Then stage 2B, when N1 node could be there, chemotherapy, re-resection when R0, R1 or R2 is there, re-resection plus chemotherapy and sequential or concurrent chemotherapy with radiation therapy should be there. And then stage 3A onwards, sequential chemo radiation for N2, definitely radiation, and if R0, if not for R0, R1 or R2, then sequential or concurrent chemo radiation should be administered. Then after initial treatment, more than half of the patients with resectable non-small cell lung cancer, they experience the recurrence within 5 years. Yes. So surgery plus chemoradiation or chemotherapy, 50% patient they remain cancer free and about 50 to 60% they recur. So what should be done? The recurrence could be local or distant, and overall outcomes still need to be for patients with resectable non-small cell lung cancer. So these guidelines, those where ESMO guidelines are recommended for adjuvant chemotherapy can be considered in patients with resected stage 1B disease where primary tumor is more than 4 centimeter due to clear evidence of benefit. Okay, so less than 4, observation versus chemotherapy, they're running parallel to each other. But when more than 4 centimeter, then chemotherapy has an upper hand. So since these guidelines were published before this 8th edition came, because now it is not stage 1B anymore. So as such, we are offering them adjuvant treatment, adjuvant chemotherapy. So adjuvant chemotherapy should be given to these patients who are those were operated with 4 centimeter or more disease. Then meta-analysis, that less meta-analysis, that is that explains the overall survival benefit from post-operative cisplatin or early stage non-small cell lung cancer. So, excuse me. Pooled analysis of 5 trials that evaluated the adjuvant cisplatin-based chemotherapy in 4584 patients, where cisplatin vinorelbine most commonly used agent, only combination shown to prolong the OS. And chemotherapy led to improved OS, and hazard ratio was 0.98. So absolute benefit of 3.9% and 5.4% at 3 and 5 years respectively. So chemotherapy, that too with platinum and mineralbine, had been shown. This meta-analysis has clearly established that this has shown benefit when we give this doublet. Then how this new adjuvant therapy will work, or say, or is the same as adjuvant, as there is no hidden trial on that, because the same set of patients, those where they were not stratified into two groups, where some were given new adjuvant and some were given adjuvant, not like that. So different studies were there, and there's meta-analysis forest plot has been plotted here. So we can see in stage 1B and 3A, neoadjuvant chemotherapy hazard ratio is 0.87, adjuvant chemotherapy hazard ratio is 0.89 neck to neck. So these are comparable. Perioperative chemotherapy is better, and the right side non pre this neoadjuvant chemotherapy was better. So in this set of patients, this 1B to 3A, both are showing almost equal results. So we must consider on case to case basis, depending upon various factors, patient general condition, what is the tumor burden, then what is the pulmonary function test of the patient, how the any other comorbid condition, many factors that come to play. Now coming to targeted therapies. Targeted therapy has improved the survival in lung cancer like anything. So, with introduction of EGFR TKIs, this disease-free survival is improved from 44% in placebo to 90% in EGFR TKI arm at 24 months. So, reduction in the risk of disease recurrence or death with osimertinib was more than 80%. So you can see the huge gap with placebo and targeted therapy. So as as I said earlier, we cannot omit the molecular testing these markers in this era. It will be a crime, because we are getting this much of benefit. So how can we omit that? We must do all molecular these 9 markers, and we must subject the patient with particular therapy that they are eligible for. Now coming to atezolizumab, that also showed an improvement in DFS as well as in overall survival in adjuvant setting. Atezolizumab was shown to improve in survival in adjuvant setting where the PDL1 was less than 1 to 1%, not 50%. So this is the drug that has shown that what to do with PDL1. I am there. We cannot wait for the patient's report to get a more than 50% PDL1 to administer atezolizumab when it is freely available. Means in my setting, we are supplying totally free to the patient. So there is this graph, we can see the disease free survival 48.2% to 60%. What a variation is that after 36 months. So atezolizumab is that drug, even if we are having a low PDL1, it really works. Then coming to radiation, very interesting. We can see here, you can see the targets, this middle one, this tumor, and the little green circle is the spinal cord. So in radiation therapy, we are really giving precision therapy. Precision therapy means radiation therapy that has now translated to medical oncologist precision therapy in terms of molecular marker. But here you can see tumor is there, cord is there, lungs is throughout, and we are treating only the tumor, not the adjacent structure. What a beauty! My subject is such a beautiful subject, you will fall in love with that. You can see intensity modulated radiotherapy that has been shown to improve survival in patients with stage non-small cell lung cancer 3 patients and where tumor T3 T4 burdens. But thing is that you must be having a good setup where 4D CT is there, you can control the motion, and where the PTB area would be very less, so that the pneumonitis chances will be very less. Reduce dose to heart with lower rates of grade 3 pneumonitis. Increasing dose to heart will associated with high risk of death. We can reduce the dose to 3 grade to heart. The mean dose for heart can tolerate is 26 gray, but we can reduce it to 3 gray while irradiating the tumor nearby heart in the lungs itself. So it is a very good modality, but expertise needed, and centers should be thoroughly equipped. Now coming to SBRT. SBRT is very important in any site of body where you are using immunotherapy. Many studies are now come up with the concept that when we are using SBRT and immunotherapy, they act synergistically. Even though sequentially used, that works better. The tumor that tumoricidal dose of SBRT is much more. Means we can get a much more dose with a lesser fraction. We give 1 to 5 fraction, not more than that. And per fraction we can go up to 20 grade depending on the location of the tumor and size of the tumor. Maximum we can go up to 5 centimeter, not more than that. If the patient is lucky enough to have a 4 centimeter tumor uh, away from heart, it will miraculously cure the disease. You can see the follow pictures of PET and CT. You can see that what a beauty this SBRT can do. With this era of SBRT, we can always have this option with us when the patient is eligible. And if we are planning for immunotherapy, means medical oncologists, radiation oncologists, they must work with hand in hand to plan for the patient. So it is important to differentiate between stereotactic body radiotherapy versus conventional fractionation external beam radiation, which are stage 3 non-small cell lung cancer, typically IMRT technique. So SBRT is high dose per fraction, as I said, up to 20 gray per fraction, 1 to 5 fraction with 3D targeted localization. And SBRT is used nearly in early stage lung cancer, but due to concern for toxicity, not standardly used for larger tumor. We are having up to 4 centimeter, 5 centimeter, we can very beautifully use that. Then 4D-CT planning that
Sorry to
allows,
interrupt, ma'am.
yeah,
Requesting you conclude your talk in next 2 minutes.
okay, sure. Then, okay. Then coming to chemotherapy with or without radiotherapy is standard of care after complete these patients with stage 3 lung cancer. So we can see that recommended adjuvant treatment therapy for pathology after pathological staging in stage 1, stage 2, stage 2B and stage 3, 3B, where we can always go for observation in stage 1A. Then 1B and 2A multidisciplinary team should consult and sit together. They should discuss whether observation or chemotherapy, or stage 2B when N1 disease is there, chemotherapy is always there, and stage 3 and stage onwards, then radiation must be added with chemotherapy. Then this is the checkpoint inhibition is moving to early stage to unresectable stage 3 lung cancers. So Pacific trial is there, that is a randomized double-blinded placebo-controlled phase 3 trial of consolidation of durvalumab in non-resected lung cancer. We can see what a benefit it is having, that is compared to 33.4% to 42.9% compared to placebo. So it's a magic drug, which we all know. And durvalumab demonstrated 42.9% OS at 5 years. Then coming to targeted therapy and immunotherapy in this era, everyone is using that. So these are the examples that Metexon targeted agent with very early evidence activities, crizotinib, then red rearrangement, cabozantinib, then NTRK. This is very rare in our scenario. We are not using this. Then HER2 mutation, adotrastuzumab, we are also using this. So newer targeted agents are being identified, and this will help to increase the survival. Now coming to the survival outcome with targeted therapy with advanced non-small cell lung cancer, this non-squamous variety, platinum doublet, after that up to 8 months, this is the benefit. Then after then for EGFR, ALK and RATE and NTRK ROS1 mutation, we are having specific agents where we can get more than 44 months survival benefit. And with use of the immunotherapy in today's era, we can get more than years in metastatic cases, I can say. So using body's own immune cells that use to fight against cancer, our own T cells are being engineered to fight our own cancer. So this is very interesting. Everyone is using and can see the result. So after 2012, anti-PD-1 MAB active in NSPL lung cancer in phase 1. Then it came to up now after 2021, many agents have been approved. First pembrolizumab came, then came pembrolizumab with atezolizumab, then doublet, then now this nivolumab and ipilimumab and nivolumab with ipilimumab. Excuse me, please. Yeah. So Next, coming to survival outcome with this agents, we can see with doublets and plain pembrolizumab also we can get more than 3 years survival, and checkpoint inhibitors improve survival. This is the common graph we are seeing day to day every day. So keynote has shown a very good response. Now multiple ongoing trials in adjuvant setting with immunoagents are going on, and it will empower our clinical experience more. So now coming to this is a new thing, antibody drug conjugates. This ADC binding to antigens, these are approved therapy in breast cancer, now coming up in lung cancer. Now coming to CAR T therapy, CAR T therapy is genetically engineered our own T cells that are extracted from our body, genetically engineered, and again sent to our body to fight against cancer. So it has been used in blood cancers, and now it has been in a new era is coming up in lung cancer. So very soon we will be getting that in our clinical practice in lung cancer. So my takeaway as management landscape is very fast changing in non-small cell lung cancer. Newer therapies have huge potential to improve the survival, specifically when detected very early stages, and overall survival has improved across various subtypes with molecular alteration. So the age of oral pills over infusion in case of targeted drug is an added advantage, and pulmonologist must play a huge role in early diagnosis. Yes, that's very crucial. So thank you all. Sorry for being late.
Thank you so much, ma'am, for your excellent talk on overview of lung cancer. Next, moving forward, this session is sponsored by AstraZeneca. I would like to over to you, Dr. Dharmishta, ma'am. Ma'am, am I
Good
audible?
evening. Good evening to one and all attending this meet, and I am thankful to you all for giving me this opportunity to discuss this important topic today. Can I share my screen?
Yeah, yeah, ma'am, you can.
Okay, I'm unable to share my slides actually. Can you please display the
Yeah, I'll
presentation
just
for me?
share with my from my side, ma'am. Just a
Yes,
moment.
thank you.
Ma'am, slides are visible.
Yes, thank you so much. So, my
Thank you.
topic that has been given for the discussion this evening is osimertinib as a standard of care in the management of EGFR mutant NSCLC. What is the real world evidence? Next slide. So, as we know that EGFR mutant lung cancer has shown leaps and bounds in the amount of options that we have in treating it, and osimertinib coming from a second line option to the forefront of the treatment in EGFR mutant lung cancer with an impressive PFS of 18.9 months and hazard ratio of 0.46 has been a true miracle in the lives of these patients, as the findings brought forward by the FLORA trial. The trial has been exceptional in showing an overall survival benefit as well, with 38.6 months, and this makes osimertinib the best treatment option at the level of the trial. So today we would like to discuss in this particular session whether osimertinib lived up to its expectations in the real world scenario. Next slide, please. So here we go to the basics that what the FLORA trial showed us. Next slide. Can we change the slide, please?
Yep. Ma'am, you're not audible.
Can we change the slide, please?
Yeah.
So the
Now it's
FLORA was
okay.
a FLORA was a double-blinded study that included EGFR del 19 as well as AL858R mutant EGFR mutant NSCLC with stable CNS metastasis, stratified by the type of EGFR mutation, and randomized it in a ratio of 1:1 to an osimertinib arm and a first or second generation EGFR TKI arm. And the speciality about this trial was that actually crossover was allowed for patients in the comparator arm who on progression could actually go over to the osimertinib arm after confirmation of T790M positivity. Next slide. So we can see that as far as the age, sex, race, smoking status, CNS metastasis status, and the EGFR mutant type status, both the groups were very evenly matched. Next. The primary analysis, we can see that in all the subgroups that were analyzed, the PFS is seen to be significantly better in the osimertinib arm as compared to the comparator EGFR TKI arm. Especially so, we can see irrespective of the L858R or the del19 mutation, whether the patient had CNS metastasis at trial entry or not, irrespective of the age, race, sex, we can see that osimertinib has outdone its comparator in terms of PFS. Next. And as we usually find that in trials that allow a crossover, the overall survival benefit is usually not well established, the PFS is, but irrespective of the fact that here a crossover was allowed, osimertinib lived up to its expectation in the overall survival category as well, with 38.6 months versus 31.8 months and hazard ratio of a respectable 0.79. Next. So concluding here, osimertinib had pushed its way from the AURA trial up to the frontline treatment of EGFR mutant and SCLC and become the standard of care, as was shown in the it will be shown in the next slide. Can we change the slide, please? In the NCCN guidelines that were adopted in the version 4 of 2021, that osimertinib became the preferred method of treatment for EGFR mutation positive NSCLCs. Next, please. So where does osimertinib stand when it comes to the real world study? This has been studied in 3 trials that we will be discussing here on, where multiple various parameters have been used to evaluate the role of osimertinib as a first line treatment in EGFR mutant lung cancer. The first one is a flower study. Next. The data came out in 2021, where the basis of the data has been the fact that Flora has established the PFS and the OS benefit of osimertinib. So the real world data cannot just use the PFS and the OS. It has been estimated that only 2 to 4% of the patients with cancer receive the treatment within the RCTs. So what really happens in the real world is actually something that should be assessed in real time. Next line, please. So here we can see that the median age of presentation, the number of patients who presented with brain metastasis at presentation, the distribution of 4A and 4B stage diseases, they have been very similar in this study as to the Flora trial, which was the basis of all this finding. So in our clinical practice also, we do find that around 30% of the patients can present with brain metastasis, with a median age of presentation around 68 years, and majority of the patients, around 70%, presenting in the stage 4B. So this is probably will mirror with our clinical practice as well. Next. So the inclusion criteria, as mentioned, age of 18 years or more, histologically and cytologically confirmed, with EGFR mutation status being approved as well, locally advanced, recurrent or metastatic settings as per the AJCC 8, and also eligible to receive first-line treatment with an EGFR TKI. Any other patient who has been receiving study drugs in clinical trials were excluded from this data. Next. The particular parameter that they used to establish the efficacy of osimertinib was the time to treatment discontinuation, which is a pragmatic real-world endpoint to assess the effectiveness of anti-cancer therapy in NSCLC. Also, they have commented upon the diagnostic and therapeutic pathway, which is the time frame between diagnostic biopsy, the histological report, the proportion of the patients who underwent locoregional treatment, and the frequency at which rebiopsy was performed at progression, and what were the findings of the same. The secondary endpoints included OS, PFS, ORR, and DCR as well. Next slide. So here we can see that in this particular study, we saw that as opposed to trial data, which is usually limited to patients with very good PS, poor PS, patients with comorbidities, patients with uncommon EGFR mutations, and also active brain metastasis have received osimertinib. These patients were actually excluded in the FLORA trial. The outcomes that they received were similar to the published trial data. So this makes osimertinib an even more lucrative option for the patients who were actually ineligible for the trial itself. No difference was noted in the PFS, time to treatment discontinuation, or OS, even in the elderly patients and patients with comorbidities. So osimertinib seems to be an effective treatment option in the elderly as well as the patient with comorbidities who would be otherwise not good candidates for chemotherapy. Osimertinib has also been used in less common EGFR mutations, though that becomes a discussion for a different platform out of the scope of this study, of course. Next. Here we can see that there is a wide gap in the plots for the patients who were asymptomatic at diagnosis and the patients who had less than three metastatic sites at diagnosis. These patients seem to be having a much better median time to treatment discontinuation on osimertinib. Next, please. Next. So here we can see that the time to treatment discontinuation appears to be a very good endpoint to evaluate the success of osimertinib in the real world data. The time to treatment duration was around 25.3 months. It was longer than the actual time to treatment discontinuation found in the FLORA trial. So it has been seen that osimertinib is doing better than what was actually seen in the FLORA trial. And it was even better for the patients who had three or more sites at metastasis, isolated sites of progression, that is the patients who had oligo or oligometastatic disease at progression. Next. Next, please. Also here we can see as we go on progressively clicking, the data will be highlighted that the patients who had no symptoms at diagnosis, the patients who had baseline brain metastasis, and also the patients who had three or more metastatic sites at diagnosis had worse PFS as compared to the uh, uh, ones who didn't. Continue, please. Next. Next. So after a median follow-up of 12.3 months, the PFS was found to be around 18.9. Median OS was not reached at the time of data cutoff. There were no complete responses, but there were an astounding 73% of partial responses and stable disease of 23%. So giving a disease control rate of approximately 96% in this case. Next. Here as well, we can see that the median PFS, we have already discussed this, that median PFS is better in the patients who do not have brain metastasis at diagnosis and the patients who are asymptomatic at diagnosis. Next. Next. So in the multivariate analysis as well, the superiority of PFS in the absence of brain metastasis, prolonged PFS, and a longer OS in asymptomatic patients at diagnosis, and a time to treatment discontinuation of 9 months or higher, corroborating with a much better OS with a p-value of 0.008 and a hazard ratio of 0.145. This was noted in this particular study. Next. In the real world therapeutic pathway, was established to be an essential element in the evidence-based medicine, and this could actually help a clinician in his further decision making. Among the patients who experienced a progressive disease, which numbered to around 44, 47.7% of the patients underwent a rebiopsy at progression, which was 66.7% cases a tissue rebiopsy, and 28.6% a liquid biopsy. So as we know that in lung cancer, usually tissue is the issue. So we cannot ignore the role of liquid biopsy in this case, though of course tissue biopsy is way more important, as discussed already by my previous speaker. Molecular analysis was performed in around 61.9% of these samples, and druggable resistance mechanisms that were found included MET amplification as well as EGFR amplification, and a HER2 amplification. Next. Concluding to safety data, as we will see in the upcoming highlights, that pneumonitis, diarrhea, and stomatitis were one of the more important adverse effects that were taken into consideration, though possibly a little more important than highlighted by the FLORA trial itself. Please continue with the highlights, please. So 87% of the patients experienced adverse events and 33% had grade 3 or 4. Venous thromboembolism is found to be an important adverse event. In the real world ASTRIS study also, grade 3 pulmonary embolism was seen in around 2% of the pre-treated patients who were receiving osimertinib. Next. Though they tried to stratify the factors that could be predisposing to the venous thromboembolism, they could not find a particular association with age, performance status, comorbidity, or the tumor load. Next. No difference was noted in the survival outcomes according to the age, comorbidity, type of EGFR mutation, and osimertinib continued to be effective in the real world scenario as per the study. Next. Coming next to the OSI FACT, which studied osimertinib as a first-line treatment for advanced EGFR mutation positive NSCLC in the real-world setting. The data came out in 2021 in the European Journal of Cancer. Next. So, re-emphasizing upon where the data comes from in the FLORA study. Next. This study included advanced EGFR mutant NSCLC with osimertinib as the initial treatment, and the patients who were concurrently getting any other anti-cancer agent, undergoing thoracic radiation, undergoing post-operative adjuvant chemotherapy, receiving osimertinib as second line, were not included in the data. Next. So as the baseline characteristics go, again, the median age is around 71. And this is similar to the real world scenario. This is similar to the previous study that has been quoted. This is almost similar to the median age of presentation as seen in the FLORA. As we see here, around 49% of the patients were DEL 19, 45% of the patients were around L858R, and around 65.8% of the patients are in the stage 4, which is almost similar to the previous data that has been shared. Next. Next, please. The primary endpoint here was the PFS. The secondary endpoint used were OS, time to treatment failure, response rate, safety, and post treatment. They also looked at the objective response rate, the disease control rate. Next. PFS events occurred in 182 of the 538 patients with a median PFS of around 20.5 months. This is similar to the time to treatment discontinuation that was seen in the previous study. Next. The parameters that were associated with adverse PFS outcomes were male gender, the presence of malignant effusion, liver metastasis, and presence of advanced unresectable disease. Next. With respect to the PDL1 expression, the median PFS was not reached in the patients with PDL1 TPS of less than 1. It has been reached and correlates in an adverse manner with the presence of TPS expression, though we do come to a conclusion that this probably correlates with the fact that presence of an EGFR mutation makes the microenvironment of a tumor immunologically cold. That has possibly something to do with the TPS expression as well. But this needs further study as to how does the interaction between EGFR mutation and PD-L1 TPS play out in the clinical scenario? Though we know that we do not characteristically opt for immunotherapy in the patients who are EGFR mutant. Next. So here again, as we have already reiterated, that the presence of male gender, presence of malignant pleural effusions, presence of liver metastasis at diagnosis, the presence of PD-L1 expression, they all correlate with an adverse uh, PFS outcome. Next. So the treatment discontinuation profile, as we can understand that the most important cause for the treatment discontinuation was actually the disease progression itself. Here we can see that there is a significant amount of patients who developed pneumonitis, 25.6%. And the other various causes for which the treatment were discontinued in around 16% of the patients is a myriad of events like anorexia, skin disorders, QTC prolongation, fatigue, anemia, thrombocytopenia, GI bleeding, neuropathy, paronychia. And in around 14.2% of the patients, there have been a collection of causes like the patient did not follow up on patient's request, the treatment was changed, or the treatment was changed on doctor's judgment. So, what is concerning to us is the 25.6% of pneumonitis that is visible in the real world setting. Next. So, this is reiterating again. But the thing to be noted in this graph is that the median duration of onset of the pneumonitis is around 56 days. So the vigilance begins quite early in a treatment for a drug whose actual PFS is around 18.9 months. The vigilance of pneumonitis should start very early in our clinical practice. Next, please. The overall response rate was found to be around 76.2% in the real world. Disease control rate is around 94.1%, which is similar to the flower study. PFS is better with osimertinib than with conventional EGFR TKIs, and it is irrespective of the PDL1 expression. Median time to treatment failure was around 19.1 months, corroborating with the PFS of 18.9 months in the flora. The median time from the start of treatment to the onset of adverse effects was 56 days. Pneumonitis of all grades is seen in around 12.8% of the patients, and around 4.5% of the patients can experience grade 3 or higher pneumonitis. And it may be fatal in a certain small percentage of patients. So the vigilance for pneumonitis should come very early in the use of osimertinib. Next, please. The real world study of EGFR mutant locally advanced or metastatic NSCLC treated with frontline osimertinib, published in JTO. This is again a real world, it is a registry based study where patients were studied between the time of 2018 to 2020. Osimertinib, again, as we know, reiterating what has been already proven in the flora, that it is the treatment of choice for frontline management of EGFR mutant advanced and metastatic NSCLC with a PFS of 18.9 months and an OS of around 38 months. And this study reported the real world time to next line of treatment bar death, or the real world time to treatment discontinuation in the patients with advanced EGFR mutant NSCLC. Next. So this is a global observational prospective cohort that was going on in the US, Europe, and Asia, and involved the analysis of registry and electronic health records from country-specific data sources. The US sub-analysis included data from the nationwide Flatiron Health electronic health record derived from the de-identified database. During the period, de-identified data was taken from around 280 US cancer clinics in around 800 sites of care. For the interim sub-analysis, data was collected up till June 30th of 2020. The study was ongoing and the study period had been planned till June of 2023. The inclusion criteria were 18 years and above age with advanced stage 3B to stage 4 of NSCLC, EGFR mutant having been documented prior to initiation of frontline osimertinib, and frontline osimertinib having been initiated from April 1st of 2018 to March 31st of 2020. Next, please. So this shows the the schema of the study, where between January 2011, where advanced NSCLC diagnosis start date, up till April 1st of 2018, where the actual patient identification start date started. The patients were taken into the identification window between April 1st, 2018 till March 31st, 2020. And after that, the follow-up was continued and the interim analysis was done at June 30th of 2020. This is the data that we will be discussing. Eventually, the data analysis was planned till 2023. The baseline clinical and demographic patterns have already been summarized. The Kaplan-Meier curves were used to analyze the TT-NTD and the TTD. Next, please. So age, again, as we see, the age of presentation around 70, which is similar to the flower trial and the ossifac trial. The racial distribution, the region, though not very useful to our discussion. The age of presentation and the distribution in the age groups is similar to what we find in our clinical study. Next. Again, we can see that majority of our patients are in the stage 4, that is around 80% of the patients are in the stage 4. Non-squamous histology contributes to around 97.4% of all the cases. And around 41.6% of the patients had around 2 to 3 sites of metastasis. 14.4% had liver metastasis at diagnosis, and as we find in our daily practice, around 30% of the patients presented with brain metastasis at baseline imaging. Next, please. This is an interesting graph to see that, of course, we are dealing with EGFR mutant NSCLC. Around 51% of the patients were EGFR del 19 mutant and around 33.7% were L858R. This is slightly higher than the previous study that we have come across. But what is to know that a small percentage of people tend to have both together in the study, that is EGFR del 19 plus an L858R. There are around 4% of the patients who had common as well as uncommon EGFR mutation coming together, and 9.5% of the patients had uncommon EGFR mutations only. Next. So around 58.0%, that's around 58% patients remained on the frontline osimertinib at the first interim analysis in 2020. 18.8% of the patients had received gone over to second line treatments that could be including PD-1, PD-L1 monotherapy combination therapies, other EGFI TKIs and combination therapies, and chemotherapy as well. 18.4% of the patients had died on frontline treatment, and 4.7% of the patients had discontinued frontline treatment. Next. The median follow-up time by that time had been around 9.6 months. The real-world time to next treatment or death was 7.9 months, which seems to be correlating with the PFS that was found in the FLORA trial and the time to treatment discontinuation that was found in the previous studies. 18.4% had died on frontline treatment, and around 18.8% had switched to second line therapy, as already discussed. Next. In the multivariate analysis, the factors that correlated significantly with real world TT-NTD in an adverse manner were the advanced stage at initial diagnosis, smoker status of the patient, a Charleston's comorbidity index of 3 or more, and the number of metastatic sites 4 or more contributed to an adverse RWTT-NTD. Next, please. The real-world time to treatment discontinuation was around 17.2 months. During this, 42% of the patients had events that we have already discussed before. 18.4% of the patients died on initial therapy. 18.8% switched over to second line, and 4.7% discontinued due to various reasons. Next. In the multivariate analysis again, similar factors with a high Charleston's comorbidity index, a poor ECOG performance status at diagnosis, the EGFR mutation type, of course, where uncommon EGFR mutations were found to correlate with a worse outcome in this patients. 4 or more metastatic sites and evidence of liver metastasis at diagnosis contributed to early treatment failure. Next. The take home message from these studies was that it was a true insight into the real world situation of osimertinib being used for EGFR mutant NSCLC in the frontline. The US subpopulation was specifically analyzed in this, and RWTT-NTD and RWTTD were found to be good surrogate markers for efficacy in the real world population. Longer outcome data definitely might be available because the study continued till 2023, but that is beyond the scope of my presentation today. Next. So that brings me to a conclusion today. As we can see that osimertinib has lived up to its expectations, starting from the FLORA trial and coming down to our real world practice. And that is what we do come across in our daily practice in our OPDs as well. Thank you so much for a patient hearing.
Thank you so much, Dr. Dharmesha Basu. Next, I would like to invite Dr. Varun Goel. This session is sponsored by AstraZeneca. Dr. Varun Goel is the senior consultant medical oncologist at Rajiv Gandhi Cancer Institute, Delhi. He will be speaking on remaining CNC meditation and EFM advanced lung cancer, how to treat and compare. Over to you, Dr. Varun Goel.
So, first of all, good evening, everyone, and sorry for the late joining. I was busy for some family function. So, please share slide from your side.
Just a moment, I'm just sharing the slides now. Varun, so the slides are visible.
So, topic given to me for discussion today is reimagining CNS mutation in EGFR mutated advanced lung cancer patients, and what treatment we should adopt, what is the recent advances, and how different treatment options compare to each other. So for this talk, as already have been told, that this talk is sponsored by AstraZeneca. So that is my these slides are also provided by AstraZeneca only. So to begin with, first of all, we should know that lung cancer is not a single cancer. It initially we have divided lung cancer patients according to histopathology. That is very crude method, and as a conventional teaching, we have divided as a small cell cancer versus non-small cell lung cancer. But today, in today's era of personalized medicines and with next generation sequencing test and all the different mutations and all as per recent researches, we all know that almost 60-70% patients of lung cancers are because of one or different driver mutations. And most common one out of all is EGFR mutation, especially in the Asian subcontinent. And different other driver mutations can be found if we do whole genome sequencing or next generation sequencing in the lung cancer patients, especially non-small cell lung cancer patients. It includes BRAF, MET, HER2, ALK, ROS, and TRK, and other driver mutations. So non-small cell lung cancer account for 80-85% of all lung cancers, and EGFR is the commonest actionable mutation out of all. Next slide. And we can see here that there is marked geographical variation in the EGFR mutation prevalence. As I'm telling you that EGFR mutation is more likely found in Asian subcontinent. In European country, it is around 15%, but in Asian country, it may go in few areas, in few geographical area, in few studies, it may go up to 60%. In India, we usually see in our practice, EGFR mutation is around 30-40%. Next slide. So one more point to be noted here that these patients with lung cancer, they have highest rate of identified brain mets, either at the time of presentation or maybe during the natural history of the disease during the treatment. And these harboring of brain mets and formation and suffering from brain mets is more common if patient is having EGFR or ALK mutation. Not just parenchymal mutation, the patient may also have leptomeningeal mets, So at final follow, 44% of the patient of EGFR mutation tumors had brain mets compared to the 22% of patients in which EGFR is wild type. Leptomeningeal metastasis has poor prognosis, I may say worst prognosis if not treated, and then survival is only 4 to 6 weeks. Leptomeningeal mets may be more frequent in patients with EGFR mutated patient if we compare with the wild type. Next slide. Approximately 10 to 20% of the NSCLC patients have brain mets at the time of diagnosis, and approximately 40% will develop brain mets during the course of the disease. So, for planning of these treatment planning for these patients, this point should be in our minds whether maybe patient is asymptomatic, but up to 20% patient, 1 out of every 5 patients may have some form of brain mets at the time of presentation. Otherwise, around 50% patients are going to develop brain mets if not at the presentation. Next slide. So treatment should also be like that, which is most effective for the CNS mets, because almost every 1 out of 2 patients is going to have brain mets. So we should opt treatment that is most active for the CNS disease. So because if we see according to sites of mets, it affects quality of life. So obviously, if patient is with adrenal gland, then there may not be any decline in the quality of life. Similarly, if this disease in the liver, few lesions in the liver, patient is not bothered upon, no changes in the LFT. But if disease in the brain, then is the case, as we can see in this bar diagram, most decline in the quality of life if patient present with the brain mets. Next slide. So out of all TKI for these EGFR mutation positive patients, like from first, second, and third generation TKI, which TKI we should go for as a standard of care for these patients? So brain is a sensory site for invading metastatic tumor cells as it is protected by blood-brain barrier. Up to 40% of the patients with non-small cell lung cancer with EGFR mutation will develop brain mets. EGFR TKI are also substrates for the human blood-brain barrier efflux transporter to varying degree, and this influences the distribution of compound in the brain at equilibrium. Hence, it is imperative that out of all GFR TKI, we should choose with that having best blood-brain barrier penetration. Next slide. And it has been seen the preclinical studies that osimertinib, that is third generation EGFR TKI, it differentially penetrates the intact blood-brain barrier in the monkey brains in these studies. Next slide. And demonstrates higher mouse blood brain concentration than the other TKI if we compare with the first and second generation TKI. So these studies on animals shows that osimertinib has highest brain penetration out of all EGFR TKI which have been studied till now. Next slide. Next slide. This plot is to emphasize difference in the CNS concentration out of all. So osimertinib causes tumor regression in these EGFR mutation brain mets mouse xenograft model. Next slide. And this drug was homogeneously distributed in all regions of the brain in healthy volunteers also. So previous 3 slides are regarding mouse xenograft or animal models in preclinical models. If we see next step is in healthy subjects. So in healthy volunteers, osimertinib was homogeneously distributed in all regions of the brain. Next slide. And achieves brain exposure in patients with EGFR mutation, advanced NSCLC with brain mets. This is in the patients. So regional distribution and binding of this carbon osimertinib on PET parameters image showing total volume distribution, and osimertinib achieves brain exposure. Next slide. So osimertinib binds irreversibly to the clinically relevant mutation EGFR kinase forms to selectively inhibit mutant EGFR kinase activity. It prolongs PFS and OS related to first generation EGFR TKI. It exhibits anti-tumor effect in the patient with NSCLC harboring various EGFR mutation. There is high blood-brain barrier penetrations and brain exposure if we compare with the other EGFR TKI, and it inhibits growth of CNS mets in patients with EGFR mutation positive NSCLC. Next slide. How does this efficacy of osimertinib compared to the first generation TKI in the treatment of NSCLC with EGFR mutation. So we have done some we have seen some preclinical studies in which brain concentration is high with the osimertinib. We have seen in healthy volunteers brain penetration is high, but if that reflects in efficacy also, that to be seen. Next slide. So landmark study regarding this third generation TKI osimertinib is FLORA. This is in EGFR mutated metastatic NSCLC patients which are previously untreated, so first line. So in these patients which have been recruited, majority of the patient had metastatic disease with 35% having visceral mets and 21% having CNS mets. As per the Western literature, as I would have told you that up to 20% patients may have harboring CNS mets at presentation. In this study also, out of all recruited patients, 21% patients already having CNS mets at the time of presentation. Next slide. So this table is regarding efficacy of osimertinib in the first line treatment of these patients, and PFS is a direct measure of drug benefit. So in a patient with known or treated CNS mets, median PFS was 15.2 months versus 9.6 months with the first generation TKI. So osimertinib had significantly longer OS than comparator EGFR TKI at 24 months and at 6 months. So that is 74% versus 59%, 54% versus 44%. So third generation TKI in out of all EGFR mutated patient in any case is promising results and statistically significant OS benefit. And if we do subgroup analysis and if we see CNS mets positive patient, even there this drug is showing wonder and showing significant positive results. Next slide. So this is regarding progression-free survival and in those patients in which CNS mets were there, or if we compare with those patients which CNS mets were not there. So CNS progression event occurred in 6% of the patient if receiving osimertinib versus 15% of patient if other first generation TKI was given. In FLORA trial, osimertinib demonstrated a superior systemic PFS benefit regardless of the CNS disease status at the study entry versus other EGFR TKI comparator. Next slide. So if we see with the CNS full analysis set, out of all patients, in osimertinib arm, 61 patient, in comparator arm, 67 patient. So median CNS PFS not reached with osimertinib versus 13.9 with the first generation TKI with a hazard ratio of 0.48. CNS overall response rate is 66% versus 43% with odd ratio of 2.5. Next slide. So regarding this intracranial PFS, we can see here in this Kaplan-Meier plot about this PFS, there is clear-cut benefit with osimertinib. There is both the lines are well distant to each other, no crossing over till the late follow-up, and this difference in benefit is from the very beginning. And median CNS PFS is not reached versus 13.9 months with a ratio of 0.48 with median follow-up of around 13 months in osimertinib arm. So CNS PFS was statistically significant with the osimertinib versus if we compare with the comparator arm. Next slide. So CNS progression by independent committee review occurred in 20% patient in osimertinib while 39% in the comparator EGFR TKI. Next slide. So this just not only treat, it also prevent to further happening new CNS mets. So in if FAS analysis, which included patient with or without CNS mets, at the trial entry, investigators assessed CNS progression event were observed in 6% versus 16%. Next slide. So if patient is continuing to receive first-line trial drug, like osimertinib versus EGFR TKI, then at 12 months, patient who are remaining on the study treatment is 70%. At 36 months, this number is 28%. It comparator arm, it is only 9%. Next slide. The first line osimertinib may delay the need of subsequent therapies, and 28% versus 9% patients are still going on the first line treatment, but this number is too difference is too big. Next slide. Is there any real world evidence also beside FLORA trial for these CNS mets patients? So rapid intracranial response have been achieved with osimertinib without radiotherapy in NSCLC patient, especially if they are having EGFR T790 mutation. There are 2 case reports. Next slide. So case one is 67-year-old woman. So initially she underwent middle lobe resection of the lung because 9 years ago it was early stage only, but later multiple lobes emerged in the both lungs 7 years late after the surgery, and mutation was found EGFR L858R. So definitely was administered as a first line therapy, and after 3 lines of cytotoxic regimes, including PEM and CARB, um, erlotinib was administered as a fifth line chemotherapy. So, 6th line chemotherapy also have been given. Special MRI examination detected multiple thoracolumbar bone mets. So, as 7th line chemotherapy, osimertinib was administered from the next day of the treatment. The brain nodule was detected, and on the day of 5 after administration of osimertinib, a chest X-ray revealed shrinkage of the right pulmonary nodule. CT made on day 13 revealed complete remission of the brain mets except for one lesion in the left frontal lobe. So, we have seen in our clinics patient get benefit symptomatically very rapidly if these TKI were given, especially with third generation TKI. And point to be noted here that uh, even brain mets which were there in the initial scans, just within 2 weeks, those have disappeared. Next slide. So in this patient, initially underwent right middle lobe resection of the lung, multiple nodules emerged 7 years later, and on NGS, it was found to be L855R mutation in exon 21. Initially, gefitinib was given as a first line. Patient took that for around 3 years, but after 3 lines of after that progression, 3 lines of cytotoxic chemotherapy was given. Initially, PEMCARB, and then Tegafur with bevacizumab, and after that, Docetaxel. But as a fifth line, osimertinib was given. So after 2 courses of immunology administration, 6th line chemotherapy was also given. Radiotherapy was conducted to control pain. Bronchoscopy was conducted to rebiopsy to detect if any additional T-cell mutation was there. So as 7th line treatment, osimertinib was given because now in this rebiopsy, T790M mutation was found, and based on which osimertinib was given to this patient. From the next day, brain nodules were detected. Next slide. Initially, we can see here multiple brain mets at baseline, but complete remission of the brain mets except for one after 13 days of osimertinib treatment. Similarly, initially there is right pulmonary nodule is there, but that has shrunk within 5 days of osimertinib administration. Next slide. Similarly, another case, 76-year-old man, old with significant comorbidities, but 22.5 pack year smoking history. Here also 10 years back, early lung cancer surgery was done, but on recurrence, EGFR mutation analysis was done, and exon 19 mutation was found. At the time of recurrence, patient already having multiple bone mets. Initially, gefitinib was started. He had taken for around 4.5 years. After that, afatinib was administered for around 10 months. As if, after that, PEMBEV, fourth-line chemotherapy, Tegafur was given. Osimertinib was administered as a fifth-line treatment because, and again, synthesis and for NGS was sent, and the T70 mutation was found. On day 14, there is significant decrease in the perfusion and shrinkage of pulmonary nodules, which were recognized apparently only chest X, and shrinkage of multiple lung mets and decrease in the left side perfusion also have been found later. Next slide. So in this patient with 22.5 pack year smoking history, already the 10-year back, left lobe, upper lobe resection have been done. But on recurrence, EGFR mutation status was found in exon 19 deletion. So multiple bone mets initially were treated with gefitinib, and this treatment was going on for around 1.5 years. After that, afatinib was administered for around 10 months, but later fourth-line chemotherapy was given. Photosynthesis was conducted, and because patient PS deteriorated further, in any case, T-cell mutation was found, so osimertinib was started as a first-line treatment. Next slide. So just within 10 days of administration of osimertinib, brain CT reveals remission of single brain met. On day 14, decrease in the perfusion. On as a month monitoring, chest CT image revealed shrinkage of multiple lung mets and decrease in the air-filled air side left side perfusion. His ECOG performance has gradually improved to 1, and there is clinically significant effusion is decreased. Next slide. Complete remission of single brain mets after 10 days of osimertinib treatment can also be seen here in this figure. So these are not hypothetical cases. These are original and real world cases in which within 10 days or 14 days, this drug doing wonder. Next slide. After 14 days, decrease of fusion, shrinkage of pulmonary nodules. After 31 days, shrinkage of multiple lung mets and decrease in the left side fusion also could be achieved. Next slide. Similarly, there are multiple case reports in the literature, including complete remission of multiple brain mets in a patient with EGFR NSCLC patient first line osimertinib treatment without radiotherapy. In this trial also, in this study also, they highlighted that at present, if any driver mutation is there, if patient is not in imminent threat, then WBRT should be avoided wherever possible. Next slide. So in this patient, 74-year-old woman with no history of smoking, but blood C level are increased. CT scan revealed 40 millimeter shadow in the upper lobe of the left lung. Multiple bilateral small nodules in the entire lung field also there. Have been diagnosed with T4N1 M1C stage 4B, and more than 20 multiple asymptomatic brain mets also were there. Osimertinib was started and WBRT was deferred. Next slide. So this T4N1 M1C stage, 40 millimeter wide shadow of the upper lobe of the left lung can be seen here, and multiple bilateral small nodules in the entire lung field were there. Next slide. But with osimertinib, out of all those lesions have regressed and complete sinus response was confirmed. Next slide. So recently, in August 2023, this trial, intracranial outcome of de novo brain mets treated with osimertinib alone in patients with newly diagnosed EGFR mutation and CLC patient have been published, which may be further sort out our confusion that for brain mets in an SLC patient, especially if they're in mutation, no need to go with immunotherapy. We can give chemotherapy later. Next slide. So in this retrospective cohort study, patient was selected from institutional database and had a diagnosis of EGFR mutated NSCLC, were treated with osimertinib from 2014 to 2022, received osimertinib alone as initial therapy, had at least one intact brain mets, not previously treated with systemic or local treatment. So she had baseline brain met MRI before and at least one scan after osimertinib initiation. Next slide. You can see here at baseline pre-osimertinib scan, there is significant number of lesions with cavitary appearance. Those lesions regress of the disease observed within post 2 months of osimertinib, and after 34 months of osimertinib, disease control was still seen until the 34 months of post osimertinib, and still patient CNS disease in response. Next slide. So there are 36 patients who had a median interval of from brain mets diagnosis to first time osimertinib initiation is around 25 days. But in total, these 136 previously untreated brain mets patients were tracked from baseline, and this reflects the best objective response of for 100%. Next slide. So based on these FLORA trial results, real-world studies, real-world evidence, case reports, whether guidelines also incorporate this in about this CNS activity of osimertinib. Next slide. Yes. So all major guidelines in NCC and ESMO all include third generation TKI as a preferred agent. Next slide. Even if brain mets were there upfront. Next slide. Yes, osimertinib is category 1 recommendation, preferred and recommendation out of all other TKIs. Next slide. So with this, thank you, and the house is open for any query. If you have any comment or query, you can unmute yourself or write in the chat box.
Much, Dr. Varun, for this excellent talk. Uh, So now we come to the end of the day as we conclude the day of today's oncology cancer treatment update session 2025. My sincere thanks to all the distinguished speakers for sharing their valuable insight. A special thank to our sponsor AstraZeneca, Zydus, and FK for their generous support. We appreciate your participation and look forward to welcoming you at our future sessions. Thank you so much. Any closing remarks, Dr. Varun?
Yes, thank you all the participants who have joined. Thank you, uh, AstraZeneca, Virgin Scapi, and Chidus for this sponsoring this session, because their sponsorship only make these type of events successful. Thank you, faculty, for sparing time, and audience for patience listening, and thank you for the seamless conducting of this meeting. So yes, good night, everyone. We will meet again for the next session, maybe in near future.
Thank you so much, sir. Thank you for your presence, sir. Thank you. Good night.
Good night. Good night.